Good afternoon, everyone, and welcome to the final session of the day. I can see people are still joining us, so I'll just give people another few seconds before we begin. Okay, so this afternoon's panel session is on the topic of well-being, which has come up in a number of sessions throughout our conference so far. And I want to take us back to the start of the pandemic, in fact, and some of our thinking behind why we thought this was such an important topic, and where SET and colleagues have been on that journey over the last 18 months or so. So I don't need to tell this audience that health workers have been at the forefront of the response to the pandemic. They've developed new skills, but they've also been exposed to huge trauma and have been faced with unprecedented challenges. And here at SET, the team have decided to open up a bit of an inquiry, much in similar way as we have done with other things like innovation and more recently with our work around diaspora and experts in our midst. My name is Lisa Kelly. I'm currently the Director of Strategy at SET, and I'm on secondment from my role as Chief Operating Officer at Nottingham University Hospitals, where I was leading the pandemic with my colleagues up until April of this year. We know that health workers prior to the pandemic had been predisposed to work-related stress and burnout. They're not new phrases to us, but they've certainly been exacerbated over the last period. And a further consequence of some of those well-being challenges has been related to staff leaving the profession, posing a real significant threat to recruitment and retention and the wider implications on our workforce planning. Prior to the pandemic, we knew that there was a shortfall of nearly 18 million healthcare workers that was predicted to hit by 2030. SET's been at the forefront of the UK partnership response to COVID-19 globally. We've been convening UK healthcare workers with counterparts abroad. We've witnessed ties of professional friendship maintained and grown throughout the last 18 months. Despite the extreme pressure that all healthcare workers have been under, they found that time to continue those relationships. And staff involved in those partnerships talk regularly about the psychological and the clinical benefits of engaging in global health activity. We know that personal and professional benefits of health workers participating in health partnerships and volunteering has a positive impact on people's well-being. It can enhance life satisfaction, and it can give real purpose and meaning to people's roles, reminds them of why they came to the profession. We really believe at SET that there is a meaningful link between global engagement and improving the well-being of healthcare workers. And so we started off an inquiry in the summer of this year. We set up a steering group chaired by Sir David Nicholson, who's the former Chief Exec of the NHS, to research, to understand, to inquire how we could build the evidence base to support that hypothesis. We convened a steering group at the beginning of September. Some of you may well have been there. We had over 100 attendees from 30 different countries and 14 speakers. We explored the definition of well-being, that it's personal, it's subjective, that it can be measured, and that it's vital to the health and productivity of healthcare workers. During the first session of that webinar, we explored what the drivers of workplace wellbeing were and the evidence around that. And what we learned is that there were three main drivers. One is around sort of safety, so the environment, the security that you work in. But the other two, very relevant to what we're talking about, were around people, your interpersonal relationships, and also the fulfillment, so your purpose and satisfaction in your role. And then in that second session, we heard first-hand personal accounts of people's experience, those people that have volunteered and how it impacted their well-being. We heard from people that it helps bring purpose to their role. They're able to meet like-minded people. They recognise the value of the healthcare system that they work in, that there's an opportunity to be part of something bigger and a real sense of solidarity. They also spoke about personal experiences of building self-esteem and confidence and preparing themselves for difficult situations in their home workplace. And of course, much of the global health volunteering recently has taken place remotely during the pandemic. So we've begun to challenge and change those assumptions about what volunteering and what global health engagement looks like. And finally, we heard about compassion and how that's linked to well-being. It's at the core of delivering health services. We've then taken that conversation into the start of our conference this year. So on Thursday and Friday, we had 2 sessions. One sharing some of the learning from that, the first webinar, and the second sort of building on the evidence. So Joanne Smithson from What Works Wellbeing reminded us that very few things impact our wellbeing as much as work does. And indeed that the research tells us that unfortunately we're at our least happy during our working years. So she highlighted the value of volunteering, its role in increasing life satisfaction, purpose and quality of life. And she reminded us that a good job provides access to engaging in meaningful activities. And then in the second session, Lucy led a breakout session, Lucy Byrne-Davis from Salford University. She led our second session on building the approach to the evidence. She reminded us that poor wellbeing leads to poor patient outcomes. And she talked of this myth of the heroic physician or the nurse as an angel, and perhaps that challenging our ability to access support when we need to. And then finally, she too shared some of her research around volunteering and translating some of those experiences from overseas, again, back to the UK. She finished too on reminding us of the benefits of solidarity and helping us to increase that ability to cope, to develop perspectives and self-awareness. So if I have convinced you that there is a sense of urgency around wellbeing and the need to act on this, what are we going to do about it? And what role can we play as a global health community? Let me now turn to introducing you to our very esteemed panel. We're really lucky this afternoon to have 3 wonderful speakers with us. We have Nick Powell, who is the Chief Exec of the Society of Occupational Medicine. Nick's held a number of roles in the NHS and the third sector. He's been a trustee for THET previously, and he's now an honorary advisor. We also have Salia, who's a filmmaker, writer, and emergency medicine doctor. She was the first British Muslim woman to attend the Royal Military Academy in Sandhurst, and today she's joining us from Jordan. Finally, we have Wisdom, who I had the pleasure of working alongside probably about 7 or 8 years ago now in my time in Zambia. He is the Chief Anaesthetic Officer and works in the Ministry of Health advising on safe anaesthesia. He's been a civil servant for over 27 years. So welcome, everybody. Thank you very much for joining us this afternoon. As we open up to some questions now, I'm going to encourage colleagues listening, please do interact with us. So either using your emojis on the bottom, putting some comments in the chat, or even better, if you've got some questions for our speakers, please put them in the Q&A section on the right-hand side of your screen. Okay, so welcome, everyone. Let me start this afternoon by referencing Cornelius, who talked to us this morning. He reminded us of the phrase that was used in one of our breakout sessions last week, that to do well, you need to be well. So let me ask you about your professional and your personal experiences about the value of good well-being. Nick, can I start with you?
Sure can. That was a really good introduction, Lisa. Really nicely summarised in terms of what's been sort of learned and how important this issue is for things like absence management, retaining staff. Something called presenteeism, which is a term we use, where people sort of turn up to work when they're not actually well, and I'm sure a lot of healthcare workers do that, and that's not actually good for anyone. Passing on germs, etc. I mean, I think over the pandemic, obviously, well-being has been challenged. It's been important. Self-care is important, and I think in terms of occupational health and our kind of approach to well-being, I think first of all, well-being has this kind of slightly wishy-washy term to it, and I think as I put in the chat, actually things like mental health, well-being, stress, well-being in terms of both mental and physical. That's where we're coming from in terms of kind of people's ability to turn up sort of fully sort of prepared at work. And I think also we take, again, that's the link I put on the fact sheet, a kind of strategic approach, where first off, there's you want to prevent kind of poor well-being in the first instance, and that's about doing effective risk assessment, good management. If you can't do that kind of primary intervention, then you should move to helping people cope through that team, that collegiality, that kind of interpersonal side. And if all else fails, then you're onto the tertiary, and that's about helping people return to work through things like occupational health. So there are those three different levels I think people need to bear in mind. And ideally, obviously, wherever you work in the world, in healthcare settings, you should be preventing it. But there's no doubt that kind of this global network and how we all it together as such, all healthcare workers in together, is important. I'm sure the evidence base will emerge, because that sense of purpose is key, isn't it, in terms of why people turn up to work. And again, well done, Bet, well done, Ben. Fantastic work to bring people together to get that shared sense of purpose.
Thanks, Nick. Now, unfortunately, I think we might be having a few technical issues. I think Salia is struggling to connect with us, and we have just temporarily lost Wisdom off this stage. So I'm sure my colleagues are doing their best to try and get people back, but it means, Nick, you might be in the hot seat for a little bit longer, if that's okay.
Yeah, that's fine. Yeah.
So
it's very difficult, isn't it, at the moment? Again, I want to kind of bring it to more of the kind of countryside and well-being, where people might think, oh, this is kind of just not important. It's very difficult at the moment. For example, if someone is double vaccinated and is COVID tested negative, but they have a cold or some kind of issue, do they go into work? Do they go into the hospital? And I suppose that's where advice is needed about what should you wear sort of face masks. Obviously the kind of primary prevention side in terms of risk assessment is to make sure what's critical, say with COVID, is that there's good sort of hygiene in terms of preventing airborne transmission. But I think when you talked about the kind of fundamental, where people are coming from in terms of well-being, it's that sort of sense of safety, isn't it? That's kind of, you want to go into work and not sort of contract COVID or get something else. So I would say that kind of a risk assessment approach and prevention of COVID, a lot of healthcare workers have died because of poor kind of risk assessments or poor sort of protection, probably through no fault of their own. And I think starting in that place in terms of people's security to go to work is a good place to start.
And Nick, is there something in the kind of concept of stigma and sort of healthcare workers being known for their resilience? And have you seen that, in your experience? Are people struggling to support or really talk about their well-being?
I think so. I think sort of disclosure in terms of saying people's mental health. Again, I kind of want to try and pull it away from well-being, which has a kind of perhaps a rather sort of soft approach, although well-being has got that hard edge. And let's talk about mental health. And it's World Mental Health Day yesterday, and people find it hard to disclose, and people should feel able to disclose. And it's a key role of managers or leadership in the culture to allow people to say, I just doesn't feel right, and just can't get over that situation, or that concept of moral hazard that Neil Greenberg talked about, where people actually feel sort of traumatized from that. But I suppose also we don't want to catastrophize, do we? I think there's been a time where people have come together. There's opportunities for growth, not necessarily one where people had stress, anxiety, but that's not necessarily a medical condition, which you've got a diagnosis of kind of depression or whatever it is. So actually, we're not that clear. As much as people have been through a kind of difficult time and still are, has that led to kind of actually big shifts in kind of how people's mental health is? We're not clear on that yet, but there's no doubt that mental health at work is an important issue. It was before COVID, and the stigma in terms of saying actually I can't cope needs to be broken out. Because if you break out that stigma, you're able to talk to your manager, then your chances of recovery are much better, and it's better workplace, better care, as you say, for patients. Patients as security or safety is at risk if people are stressed out. But we're not just there just for the patient. We have to be. There's no point being a healthcare worker if you're not looking after yourself, and you have an organisation that looks after you too, as helps the patient.
Thanks, Nick. I think we still don't have Wisdom or Salia with us, so let me dive into the specific sort of inquiry topic for THET, which is about, can engaging in global health really benefit the well-being of healthcare workers? That hypothesis, I suppose I put to you to say, is it, are we kidding ourselves? Because are people already exhausted and they just don't have the time and energy to do anything or think about anything else? Or do you think actually no, that there is something about volunteering and sort of enhancing your purpose, even at a time when you're pretty exhausted?
I think so. I think we need to see the evidence base, and always needs to be evidence based in our approach. But it feels to me, in terms of purpose, is that the global connection can help re-energize, can help people see that their organisation is coming from the right place. They're not just kind of throwing you back into the wards, and that there's a kind of when we're all in it together. So, and also I think we can learn from each other. I think that learning is inspiring, kind of re-energized to what's happening in Zambia or other countries, can help us think about how we approach things here in the UK and vice versa. And I think in the UK, obviously, we've got this dialogue around mental health that other countries can learn from. I think actually bullying and harassment, some really crunchy people who are, got horrible bosses. We did a workshop last week on that, and someone in Sri Lanka said, this is not an issue that we have thought about, and it's no doubt it's happening. So I think in the UK, maybe we can help people with how people approach bullying and harassment, and we can learn about how people in other countries deal with all these prevention, helping people back to work issues too. So I've no doubt, and I think that what THET's so great at is bringing people together to create that sense of purpose that improves. I think this conference will improve everyone's health and well-being, definitely. That's energizing.
Thank you. Thanks, Nick. Nick, I'm going to bring our chairman, Judith Ellis, into our discussion. Welcome, Judith, this afternoon. Thank you for joining us. Just wondered if you could share some of your thoughts and reflections, maybe for those that don't know, tell people a little bit about your career and your experience and the importance of well-being.
Yeah. Okay. Yes, I will. I'll come into. I've got a good signal in Blackpool, so you're all right. Yeah. Just to say, I'm a nurse by background. I'd been a nurse in 20 years in the NHS before I did any global work at all, and I was very happy, sort of just thinking I'm a real good UK NHS worker, and that's what I will do. And then I was invited to Uganda and rejected the invitation 4 times. No, I'm fine in the NHS. And eventually went out, and it totally transformed my own approach to working in the NHS. I was a director of nursing at the time at Great Ormond Street, very stressed, lots of safeguarding concerns, thought everything was very major. Suddenly go out to Africa where you see reality of life. So impressed by my colleagues who never had a day off, worked all the hours, You don't moan anymore when you're used to having 1-to-1 in our ICU, and they had 100 children with one nurse. Sort of brought me down to earth big time. Upsetting, but down to earth. And well-being wise, it totally changed my own feeling of well-being when I was working back in the UK. I'm not saying that's just being grateful to the NHS and what we had, but it was more the inspiration of seeing people working under that pressure and yet always smiling, always joking, keeping positive. And it almost was a stop moaning moment. You have to be grateful for what you've got, very protected. Was stressful, and I have to say I did speak to somebody when I came back on occasion, because I found it slightly, you can't do what you want to do. It was all too much for me. But there was that bit of well-being, and transformed my whole feeling of global health. That it was two-way, that I was getting as much back from this as I was giving. I was a little bit impatient with some of my team when they used to come and moan that they weren't 1-to-1 nursing on ICU for a change. They were 2-to-1 nursing. But I sort of dealt with that. So I think it is that bit of, it opens your eyes. It gives you a flexibility and approachability that you didn't have before, that you could really see what it meant to be under pressure. And I mean, I was talking to Ben about COVID, and I did work at the Nightingale Hospital in Manchester, and everybody kept saying to me it was terrible. And I felt slightly guilty because having worked globally in situations where, for example, we had no hot water in the Nightingale in Manchester, didn't bother me one bit. You know, I was able to adapt. It was just what was used to. We had limited equipment. It didn't worry me. And I think the thing for the team there, they kept saying to me, you're always smiling, you're always positive. I think there was an element that was global work that had done that for me. It was actually thinking these staff are not going to cope if we allow their own personal well-being to suffer. And we're in this together and we need to keep going together. I didn't bleat on about global work during that time. They didn't need to hear that. I did ask a question about, do you think calling people heroes helped? It didn't, I don't think, helped at all. I think it was far more about the government wanting the public to comply because the NHS are heroes. It didn't help my colleagues at that point. And a Thursday night, I was a bit mean, really, because they'd say, can we go and clap outside? But we were short of staff. And the answer is, no, you're here doing a job. The patients need you. To don and doff takes you a good 25, 30 minutes. No, you're not heroes. You're doing a good job and you're doing it well. But that doesn't mean you're heroes. And I think it was because of global that I had that approach to them. So I don't know if that fits with what you find, Nick, but it certainly for me, I think was quite I think it was tricky. The main trouble with heroes is we got free donuts and ice cream on Thursday night too, which was terrible for weight gain, which did nothing for my well-being.
Yeah, I agree. Just to come in on that, I mean, we did something in the Health Service Journal about this hero thing, and that we're on a sort of war footing, and that language is completely inappropriate. You know, I think healthcare workers can go into work and they should have been totally protected, and using kind of war mentality is kind of might be good for the politicians and the public, but it's totally inappropriate for healthcare professionals.
Yeah, it wasn't helpful. So no, listen, it's that well-being bit, isn't it, of keeping people going. And I have to say with THET, when we had our Thursday morning get-togethers as staff all around the world, I used to sit in the coffee lounge, as you know, at the Nightingale with my phone and talking to people in Nepal, Uganda, all around the world, and then in India. And we started to see the impact of COVID rolling out. I think we helped each other with our well-being. It was that bit of, we are in this together. We've all got different problems, but we're in this together. And it was amazingly powerful. I went back fired up to my work, and I think the THET team did too. And it was incredibly powerful. That it is really that coming together, isn't it, at times of stress. So.
Yeah, Judith, yeah. Thank you. Maybe another question for the two of you. I'm very pleased to see that Wisdom looks like we might be getting some connection back from Zambi, which is brilliant. But just while he's joining us, I guess the question for me is what are we going to do about it then? So as a global health community, what opportunities do we have with the network, the convening strength of things like this conference, to really make a difference? We heard from Steve Lee and Emma Wade, who both work at NHS EI and talked about. They were talking about the approaches in the UK to wellbeing. But what do you think we can do if we really think that global health volunteering might be one of many things in a toolbox that people might want to call on to offer bespoke, specific, purposeful, meaningful opportunities to their staff? What might we be able to do to really sort of shift thinking in the UK and beyond around sort of putting this in that toolbox, as it were?
Well, I mean, just a sort of slightly tragically kind of self-interested way, I think occupational health needs to be available around the world. We're lucky to have it in the NHS in the UK, and I put in the chat about a growing OH programme as that investment happening, because I think the NHS sees the value for occupational health to kind of retain and support staff. So, we'd like it around the world, and we've got a kind of global network of about 40 odd countries, but there's 160 odd which don't have it. So I think sharing that practice from the UK, what occupational health offers, sitting between the kind of a hospital or healthcare setting as an employer and the employee supporting those healthcare workers, I think is important. And I think what that can do also globally is, share that best practice, but also sort of bring back, that learning. I know in India they've got sort of basic occupational health service, which is actually far from basic. It's actually almost very affordable. What we UK is universal access to occupational health, or universal access to kind of an approach that focuses on well-being. And some countries like India certainly have kind of progressed well in terms of getting that kind of all-in offer. So yeah, I think that's there. Obviously supporting healthcare professionals around the world, sharing best practice, and I think if they can share that support to improve well-being, and I think that shows a way forward for a kind of global approach to improve healthcare for the health of all healthcare workers. So yeah, that's my 2 penny worth from the UK side to that sort of global sharing.
Thanks, Nick. And Judith Rhoda sort of suggesting that maybe some of the programmatic work that could get involved in is around sort of sharing that understanding and learning, that kind of mutual benefit of understanding well-being from different perspectives.
Yeah, it is one of the fascinating things when you're working abroad is you see colleagues in a situation you think, I would not cope with this. I couldn't cope with. I mean, some of the hospital stuff I saw, you just thought, how did they cope with this? And you learn so much from their strength and how they are coping. And I think it's one problem with saying we want to cut down our carbon footprint, and it's very well supporting each other as partners in partnership activity. But unless you're in country and you see that is quite difficult to share, actually. And the learning that goes with that and the support they give you when you're in those situations, you suddenly realize they're now supporting you. It's the other way around. I'm a bit with Nick. I think increasing the opportunity to volunteer, I think, would be great. But short volunteering doesn't work because you never really get to the bottom of. I mean, I went to Uganda for 20 years, so I knew them well, and that support network was really there. Going for a fortnight does really nothing. It just almost gives you a shock treatment, but not much else. So for both sides, they're shocked by you and you're shocked by them. So it's not good. So I think that can play a role there. I think a lot of the trusts need to realise the importance of it. And we know, don't we, that the trusts that offer volunteering on a long-term system, their recruitment improves, their retention improves. It obviously does have a real positive buzz on both sides if you start to get that right. But you do have to have the support networks in. And as Nick was saying, the occupational health is a key part of that. If you're going to do this, you can't just fling people in unsupported. You've got to have that structure around it to actually go both ways. So I think it's to be well-being and not dangerous does take structured planning and structures to be in place.
Thanks, Judith. Wisdom, let's see if the technology is going to allow us to talk to you. Can you hear us, Wisdom? Looks like he's there, but I can't see any sound or video. Such a shame. My colleagues have suggested we might get Wisdom and this looks promising, and Salia to perhaps record something for us that we can put on the platform, and you could have a little look at that tomorrow, so we can make sure that people can hear their voices and share their thinking with you.
Just I do think, and Judith, well said. And there's also a comment about mental health, and we're happy to work with that, or that to host a mental health webinar, because it's breaking through that stigma and discrimination and helping people who've been harassed or bullied. I think if that can sort of move forward with a sort of webinar program to discuss mental health, to break some of these stigmas, I think would be really good. And I see someone from the University of Hargeisa talking about dying, and it's difficult for healthcare workers to deal with that. I think there is a bereavement side to that, and for healthcare workers, and again, it's a team, and that interpersonal connection is so important. There's an evidence base for that, and from Professor Neil Greenberg, and in a way that this is that is creating team, isn't it? And that interprofessional connection that can help people with that sort of burden. I'm sorry to hear about, in terms of kind of people's experience, it's definitely tough. I suppose I'd just come back to, it doesn't have to be tough to the point where actually, you have PTSD or something, mental issue. If you're all in it together, you can sort of work through it. It can be a period of growth, but there's no doubt there is stigma around this area. I think that can help break the stigma in some of the countries they're kind of partnering with. I think it'll be a good thing.
Thanks, Nick and Judith. You've done a great job in keeping the panel going. So Judith, thank you for stepping in at the last minute. I'm just going to round up and let people know where we're going next with our inquiry. And then I will bring our final speaker in to close today's activity. So thank you to everyone. We've had a huge amount of contribution to this this work so far, and this inquiry so far, and I'm so grateful to the steering group for giving their time to supporting our thinking and shaping our thinking around this. If you want to find out more and you want to follow our inquiry, we have something called a Pulse platform, which I'm sure one of my colleagues will pop into the chat so you can see the link there. If you're not signed up already, then please sign up. There's a number of conversations going on there, but there is a group specifically around wellbeing where we will be updating the information. We've got a whole breadth of kind of literature around this, fact sheets and numerous things that might help you in your organisation. But we'd really like to hear from you as well if you've got some experience you think might be really valuable to this inquiry. So please don't hesitate to get in touch with us. The steering group will be reconvening as we begin to perhaps write up a report with some recommendations about how we move forward. This really is the start of that conversation, though. I think what this is doing is opening up, and we've had lots of ideas over the course of the conference and the webinar about things that we perhaps need to research a bit further. So so much more to do on this topic, but thank you ever so much. Thank you to the panel joining us today. We will try and get some words from Wisdom and Salia for you for tomorrow. But without further ado, let me please hand you over to Jed Byrne to close us out for day 3. Jed is the Director of Global Partnerships at Health Education England. He's also a practicing surgeon and an academic. And his vision has not only influenced HEE and the global health work there, but has significantly influenced our thinking at THET too. A very good friend of ours. So can't think of anyone better really to share his final thoughts for us today. Thanks, Jed.
Thank you very much, Lisa. I'm just, for some reason, the share button has gone off my screen, so I do apologise. I'm unable to share my slides at the moment for some reason. It's just vanished. Kieran, I don't know whether you can help me with this.
Kieran, if we've got a set of Jed's slides, can we post them? Can we
hold on, it's just appeared.
Oh,
okay, brilliant. Thank you very much. Okay, can I just check that you can see that?
We can, thanks, Jed.
Brilliant. Okay, I've got this strange sensation of that old expression, standing on the shoulders of giants, talking to you today, really. It was been quite an extraordinary day, and that followed up an extraordinary Thursday and Friday of last week. And I think just to start off, I'm so grateful, really, that THET has developed and matured, that it can bring such an extraordinary group of people together to have a conversation in such an important time as we transition from what has been probably the most toughest global health security time in any of our lifetimes into what I guess is a new world. Originally, this presentation was going to be an announcement of a launch of a new global strategy for the organisation that I work for, which is Health Education England. But owing to a variety of things, not least of which have been COVID-19 and some governance issues, we're delaying that launch. But what I wanted to do in the first sort of 5 minutes or so was just to tell you where we're up to with this and what the background is. Now, Health Education England is the UK's largest national health body with responsibility for workforce education and training. We developed our first global strategy in 2018, some 6 years after the Lansley report created HEE as an executive arm's length body of the Department of Health and Social Care. And it was a 3-year strategy, and it was due to be refreshed. And what's happened really over the last 3 years is we've altered our focus in no small part to our due to our relationship with THET and to what has gone on in the world, into renewing and strengthening our emphasis on partnership and peer-to-peer learning. And you don't need me to tell you that there have been a range of changes which have brought this about across the world, and those changes have certainly not stopped and consider to gather pace. We were also really keen, having gone through a new start process of about 3 years, that we got into a situation where we were reflecting the direction of government strategies, which had obviously changed and matured from a global health perspective over the last 3 years. So we have been out to consultation on a new strategy quite widely over the course of the last 3 months or so. We've consulted on 3 basic strategic priorities. One is an offer to healthcare workforce itself, where which is based on the premise, and this has been iterated really powerfully over the course of today, that if you learn within a global environment, you deliver more powerfully, more resiliently, and with greater quality locally. And we also aware that there is a mounting enthusiasm for global portfolio learning during healthcare workers' lifetimes. We also realise that by engaging in partnership, particularly place-based and institutional partnership, we can improve the offer of healthcare that we can deliver to local populations in new systems. This does not just include ethical international recruitment pathways, but much more about how engaging in global learning can develop leadership skills, can improve recruitment and retention, job satisfaction, and a wide variety of other important issues which are essential for the delivery of a high-quality universal health coverage system. And then finally, the NHS is the oldest and largest universal health coverage system in history. We've been doing this for 73 years. We employ 1.4 million people, and we believe that we have a really strong track record to engage with governments and other healthcare systems in the united effort of the globe to develop high-quality universal health coverage. So we consulted very widely on this. This is a list of all of those people that we have consulted on, and I just want to present some of those results. 81% of participants who engaged strongly agree that HE's domestic activities have clear links to a global agenda, and therefore there's a strong feeling that we can't really offer our statutory responsibilities to the health workforce of the NHS without engaging within a global context. There was strong agreement that there should be an offer to the individual and to organisational systems, and even more surprisingly, the strongest of all feelings that we should be making an offer to the global health system strengthening. We took on a wide variety of participants who provided a lot of qualitative suggestions, and we've modified our plans in accordance with those and continue to rewrite what is a dynamic document to enable us to reflect those views of those people that we've consulted with. You can see some of the suggestions here, including a global perspective on patient safety education and training, and engagement with current movements and momentums on equality, diversity and inclusion, engagement with Royal Colleges and partners across the system who are also developing similar strategies, are really very important to those people that we've canvassed. So we've now changed our strategic, or modified our strategic objectives, and I don't expect you to read all these, and I'm certainly not going to go through them all. But these objectives now, we believe, reflect the overall direction of travel of post-pandemic global health development and the direction of our own government, as well as satisfying the requests and desires of the NHS workforce itself. We are currently planning to introduce work plans on the basis of this strategy from the 1st of April 2022, and we will hopefully deliver this through our existing HEE national and regional structures and through HEE's operating model, which is currently being developed with the new integrated care systems across England. So we will seek departmental and ministerial support over October and November, do some refinements and prioritisation with the aim of having a draft strategy post SR presented to the HE board in December, and a 3-year business plan available prior to the commencement of the strategy in April 2022. You don't need me to tell you that there are significant risks associated with this, particularly the cuts in ODA and the spending review, which is just around the corner. But as has been said by many of the individuals speaking today and in the discussion, we need to recognise that this global engagement is a massive priority for developing resilient global health security over the course of the next decade or so. So that was the sort of business as usual type of stuff that I wanted to discuss with you. But actually, what I wanted to leave you with today really was some of my own personal streams of consciousness that I've been thinking about really over the course of the last 12 months. I find myself in the twilight of my own career. Having been so fortunate as a healthcare worker, not only to have had one foot in the clinical camp for all of my life, but also to have had a lot of other interests and networks and a lot of other freedoms to develop and experience transitional points between the health service and other systems, both globally and locally. Without any question, however, the last 18 months has been probably the most cathartic in my life. The pandemic has been a disaster of immense proportions, and like all great disasters that ever beset us, there's a huge amount of learning that can come from this. And I just wanted to reflect on 3 areas where I think I'll be turning my own personal thoughts to over the remainder of my career. I've labelled these levelling the playing field, empowering diaspora, and valuing our NHS workforce. I just want to go through these quite quickly. So a couple of people have asked me several weird questions over the last 6 months. So the first question somebody asked me was, why are the Indian cricket team not 20 times better than the English cricket team? And this was followed up actually a week later by the Olympic table, where the distribution of Olympic medals did not reflect populations at all and was terribly skewed. And of course, this really ultimately boils down to this whole question of differential attainment in healthcare. And what I am also aware of, having learned, like all good medics, the history of medicine and healthcare over the last 500 years, is fundamentally significant local change is delivered by local people. And where people are empowered to change activity, that is where you get the most rigorous change. Unfortunately, because of the way in which civilization has developed, most change and most advancements has occurred across the Northern European belt. And I think that what we need to do as global citizens over the course of the next decade is work with a primary focus of empowering and identifying and nurturing talent in the local communities that we're working with in our global partnerships. I think that if we do that, and if we look at really our best chances for healthcare transition, we all, as healthcare workers, in our fortunate position that we are in at the moment, need to be able to identify and help through peer-to-peer institutional support the geniuses who are going to transform local healthcare sectors in countries which are currently classified as low, middle income and transitional. This may seem obvious, but I think one of the or a group of suggestions that we might like to think about, and maybe we can discuss tomorrow, is should we start to formalize peer-to-peer global moderated learning across boundaries? Should it be compulsory for all undergraduate healthcare workers to engage in peer-to-peer action learning set development with partners in other Western economies and other low and middle income economies? The pandemic has shown us that the technology and the enthusiasm for developing those relationships is there. So should we be moving into a situation where we are making those part of what is normal business as usual for lifelong learning, rather than occasional dabbling, which has gone on pre-pandemic? I think we should probably be moving to a situation where peer-to-peer global engagement is seen as a formalized part of continuing professional development for healthcare workers. We know experiential learning and role modeling has far greater impact than curriculum-delivered didactic learning. So why are we not now awarding CPD points for participation in such engagement? And I also think that we have learned that our pathways for frugal innovation and our abilities to peer coach are being obtunded by the way in which we look at learning at the moment. And I think that these things, frugal innovation and behaviour change, should become compulsory learning outcomes for all undergraduate programmes. So the next little thing, if I've got time, is to talk about diaspora. The most moving situations that I've been involved in over the course of the last 21 months have been the juxtaposition between the desire of those of us who've witnessed major catastrophes in other countries with the pandemic management, and our inability to do anything useful with the power that diaspora organisations have had to allow us to do useful things. And the response of the Indian diaspora to the Indian surge in COVID cases at the beginning of 2021, the response that the Myanmar diaspora have had, and many others, but Ugandan diaspora and Kenya diaspora, to the challenges that the global pandemic has given us, have really brought it home to me that we are significantly underplaying that expertise in our midst. And the publication of THET's documents, experts in our midst, stress this. But I think we've got a long way to go to recognise and empower diaspora organisations for the betterment, not only of our relationships globally, but also for the delivery of our own healthcare within the UK. I think for me personally, I'm determined to positively identify and engage and promote diaspora healthcare workers in education and leadership roles. And our new chief executive, or rather not really new now, but a year-old chief executive, Navina Evans, I think fully supports this. And I also think that we ought to be introducing the notion of diaspora and diaspora-focused learning outcomes in undergraduate and postgraduate learning. And then the final thing, really, which I guess also supports what was said in the previous session that Lisa led so well, is just how vulnerable and fragile our workforce are. And that word fragility or fragile workforce, which Elizabeth spoke about in the first session this morning, has been really resonating me. We have an unprecedented challenge. My own 1.5 days a week in the National Health Service as a frontline clinician have told me that all around me there are people on a razor's edge who could very easily fall off unless we recognise that fragility and attempt to improve some of the mental health and burnout issues that are currently going on within the in the workforce. And this is in the face of some fairly stupendous financial challenges. I've been in some meetings recently where people have talked about in a recovery phase of us increasing to, and I quote, sweat the system in order to get the maximum productivity out of NHS workers as we recover with long waiting lists, etc. It's perfectly clear to me as a frontline worker that if we attempt to sweat the system without putting those support mechanisms in place, the system will fall over as individuals topple. I think being kind and supportive of our own workforce will improve recruitment, retention, well-being, productivity, and job satisfaction. And I think part of being kind is recognising the deep compassion that our frontline workforce have for our global peers. This aligns to the NHS People's Promise, and we claim all the time to wanting to make the NHS be an employer of choice. And if we're going to really do that, I think we have to empower our workforce to be global citizens. So similarly, I think we need more evidence, and we need to recognise at local system level, that global engagement and partnerships improves recruitment, retention, well-being, productivity, job satisfaction. I think a lot of us already know that, and therefore it should be reflected in national and local policy and strategy. I think we need to move into an area where there are global engagement, key performance indicators for local trust and systems, and we should be rewarding frugal innovation, which is led by frontline staff and global technical collaboration. So I think my time is up. I'm really grateful to have the platform today. I hope tomorrow is wonderful, and I'm grateful to Ben and the team and my fellow trustees for giving me this opportunity. Thank you.
Oh, Jed, thank you so much. You just absolutely epitomised there why we at THET love collaborating with you and the team at HEE. Having personally benefited from a global engagement opportunity that HEE offers to NHS colleagues, I can certainly speak from the heart when I say it really has influenced my contribution, my leadership in the NHS. So thank you ever so much for sharing those thoughts with us, Jed. Really powerful. So all that is left for me to say this afternoon is thank you very much for everyone for joining us today. We hope you'll be back with us tomorrow morning at 9 o'clock for our final day. I can't believe we're on to day 4. We've got Dr. Shams Syed from the WHO joining us, Professor Amaswa from Achest. We've got a conversation about climate and going green, and some more sharing of examples of solidarity over the last 18 months. So thank you very much, everybody, and we really look forward to seeing you back here tomorrow.